Welcome to everybody. My name is Zoe. I am the research manager at the Follicular Lymphoma Foundation. It's great to see a good turnout, and I can see some more people joining as we speak. If you haven't already, I'll put a link in the chat around catching up with our previous webinars where we cover all sorts of interesting topics. And today we begin our second series, and we will have a new webinar every roughly 1 to 2 months. So do look out for those coming up. A couple of housekeeping things. Today's webinar is being recorded, and we plan to upload the final video onto our website, where only the speakers will be visible in that video. Comments will not be visible during the recording. At the end of the recording. Thank you to all of you who submitted some really good questions at the registration, and Mitch will try to cover as many as possible today, and we will save others for future communications. Please do ask your questions throughout today's session in the chat area. You can make it anonymous if you prefer. We will have a couple of live polls, which is for everybody, no matter your experience or your link to follicular lymphoma. And finally, we'd love to connect a little more with our live audience here. So if you feel comfortable, please do share in the chat area how you are affected by FL, if you're a patient or a loved one or something else, and which country or region you're joining us from. So over to you, Mitch.
Okay, morning everybody, or afternoon, evening, wherever you are. My name is Mitchell Smith. I'm the Chief Medical Officer of the Follicular Lymphoma Foundation. This is another one in our webinar series, and today's is going to explore in some detail watch and wait, otherwise called expectant observation, active monitoring. It has a number of terms. And we've covered a little bit of this in previous webinars, which are available on our website, and you can go back and look at those. But this one will be dedicated to this area because we've carried out some polls recently on social media, and it's still one of the major topics of concern and conversation. What's the basis of watch and wait? How patients feel when they're on watch and wait? What about the uncertainty and the challenges of this? And the concern about how do I know when it's time to start treatment. So as Zoe mentioned, please participate in the polls and ask any questions in the chat, and we'll try to get to them. We don't offer specific medical advice, of course, but we can talk in generalities about certain issues. So the information and discussions today are informational purposes only. They don't constitute medical advice. Please consult with your own healthcare team for personalized medical advice. Without further ado, I'd like to introduce our panelists for today. So first, Dr. Brad Call is a lymphoma expert. He's actually oversees the lymphoma committee of one of the 3 large national cooperative groups in the United States. Brad, you want to tell us where you are and a little bit about your background?
Sure. Thanks, Mitchell. So hi, everybody. I'm Brad Call. I'm a professor of medicine faculty member at Washington University in St. Louis. My clinical practice is pretty much limited to lymphoma and chronic lymphocytic leukemia. And I've been doing this now for 25 years as a lymphoma specialist. I still really enjoy seeing patients. And a significant chunk of my weekly work life is devoted to lymphoma research. And if people want to ask questions about, what the future might look like in follicular lymphoma, I'm happy to opine on that issue as well.
Thanks, Brad. Yeah, Brad oversaw one of the key follicular lymphoma trials of whether early treatment would be beneficial. So we will definitely get into a little bit of that and what the current state of research in that area is. And Nicola Atfield, thanks for joining us. You want to tell us a little bit about your background?
Thanks, Mitch. So I'm Nicola. I was diagnosed with follicular lymphoma 8 years ago, nearly now. I've never had treatment. I've been on watch and wait since diagnosis.
Great, thank you. And so, yeah, we'll get into a little bit about how that you felt about that. And I think you'll find that a lot of the people on the webinar will be very interested in how you've dealt with this issue. We're going to continue talking here, but we're going to put the polls up. We're starting to see in the chat a number of people from, and it just shows you people clearly around the world, US, Canada, UK, Spain weighing in. So we're happy to see that. So the first poll is actually to start out to get a basis of how your current understanding of watch and wait, active monitoring, expectant observation, active surveillance, any of those terms. So what's your current understanding? Do you feel comfortable perfectly, which would be a 5, or 0? I never understood this at all. Somewhere in the middle, I suppose. And the second question would be, how would you describe your current experience? Are you relatively newly diagnosed, maybe in the last 6 months and being watch and wait, or I've been on it for a year or more? I'm living with the follicular lymphoma, but not on watch and wait. That could be on treatment, or some similarities when you are back in remission, which and back in that observation period. So while you're answering those, Brad, so, actually they came up pretty quickly, so I'll take a minute. So it's not surprisingly, a bit of a spread all over the map. A few people are very comfortable with it. A few people don't know much about it. And there's a split in the middle. And in terms of how long, interesting, about a third of patients are relatively newly diagnosed, so that for them this is going to be very germane. But also the quarter of patients who have been on it for a couple of years or more are going to be very interested in what Nicola has to say. And then there's a few caregivers and a few people who probably are on treatment. So there's a mix. So we'll cover hopefully things that will be of interest to everyone. So, Brad, this is one of the common problems with follicular lymphoma. You come in, you get a diagnosis, you get your staging evaluation, and then you come back and they're sitting across the table from you or at the desk, and they're saying, "What do you mean I have stage 4 lymphoma, but you're not going to treat me? And, we're just going to observe you." So how do you approach that? And what do you say to a patient at that? I think that'll explain a lot about it.
Yeah. Well, I admit it's very counterintuitive for patients to hear you're saying, I have newly diagnosed cancer, that you have really good treatments for it, and yet you're recommending that we do not utilize any of those treatments at this time. It's an odd thing to wrap your mind around, but there is a logic. There is a logic behind it. So I first of all, I try to de-emphasize the stage part. The stage in follicular lymphoma is really not that important of an issue. It's a huge issue in certain cancers that can be cured, with a surgery, for example. But it's probably more useful to think of follicular lymphoma as like a blood cancer. If you look hard enough, you can actually find it in the blood. And if it's in the blood, it means it's everywhere. And so that's just typical. That's normal for follicular lymphoma to be very widespread at the time of diagnosis. But even if it's stage 3 or stage 4, the prognosis is usually outstanding, really good. So I try to just sort of get people to stop focusing on the stage part, because it just isn't that important. What's more important, frankly, is the tumor burden. And so the way I try to explain it is to a patient is like, suppose I could take all the lymphoma cells out of your body and I could make a pile. How big is the pile? And some people have a high tumor burden, And we have criteria for that. And those are the people we recommend starting on treatment sooner rather than later, because we don't want them to start feeling sick from the lymphoma, or they might have some symptoms already, and we want them to feel better. And we can accomplish that by initiating treatment. But a lot of patients, the pile is small, and we call that low tumor burden follicular lymphoma. So if I have a patient with low tumor burden follicular lymphoma and they have no symptoms, then they're a candidate for this watch and wait strategy. And then we'll say, well, why wouldn't you just treat it now? So then that gets into this whole issue of curability. So I will say to patients, if I knew I could reliably cure your follicular lymphoma with this treatment, of course, we would pull it out right now and we'd do it and just put this behind you. The problem is, even though our treatments work well, I think it's fair to say they don't reliably cure follicular lymphoma. Follicular lymphoma is a little bit of a weird cancer in that it's very slow moving and it can come back after 5 years of remission, or 10 years of remission, or 15 years of remission, or 20 years of remission. And so it's hard to say with confidence to any individual patient, hey, I think you're cured, because we see these late relapses. So the curability of this disease is not clear. So that's another reason that we sort of hold our treatment back for selected patients, and you sort of pull it out when it's more timely, when it would make more sense. So then they might say, well, why do it later? Why not just do it now? Even though you can't cure it, I'd rather be in remission, Dr. Call. So then I will explain to them that we've done studies. And this goes back, 30 years, 40 years, when all we had was chemotherapy. And we've done studies where you have 500 patients with low tumor burden follicular lymphoma. And in these studies, half the patients would start on chemotherapy right away, and the other half would start on observation. And for the patients who start on observation, then each individual patient starts their treatment when their disease crosses that threshold into high tumor burden. So for one patient, it might be 1 year later. For another patient, it might be 5 years later. For another patient, it might be 10 years later. And so you have, 250 patients who started on treatment immediately, and you have 250 patients who started on treatment at some later date on a case-by-case basis. So then if you follow those groups of patients over time, and you look at the proportion of patients who are alive 5 years later, 10 years later, 15 years later, it's identical. It's the same. So to take all those patients and start them on immediate treatment did not improve the likelihood of being alive 5 years from now, 10 years from now, even though the treatment put them in remission. And there's always a price to pay for treatment in terms of side effects and what it does to your immune system. So then you have to ask yourself, is it worth it to go through those risks if it doesn't improve your likelihood of being alive 10 years from now? And then when newer drugs came along, like rituximab, which is immunotherapy, more targeted, doesn't have all the side effects of chemotherapy, we repeated those studies with rituximab versus observation. And we showed, yep, we can put your disease in remission with rituximab, pretty easy to do. But then if you look at the proportion of patients alive 5 years later, and now we have 10-year follow-up, it's still the same in both groups. So to take our good treatments and deploy them immediately does not have obvious benefits against the cancer in terms of making people live longer. And so that's why we usually recommend just like holding your ammo, holding your ammunition back and using it when at some later date, when the tumor burden starts to get closer to a high tumor burden. And that allows patients to kind of walk around planet Earth free of treatment and treatment side effects and treatment risks, sometimes for years and years and years. Having said all that, Mitchell and I totally recognize the psychological difficulties of adapting to that for some patients. It can be very difficult, and I'm sure Nicola will attest to that, and I'm sure people on this call will attest to that. And I'll be real upfront and honest with patients about that, and I'll say that's the real challenge, is getting psychologically comfortable with this strategy. And what I've learned over the years is many patients do adapt very nicely to the strategy and get comfortable with it over time. I do occasionally have patients who just don't. You know, we start out on this strategy and I'm seeing them like every 3 months, and the watch and wait thing is clearly having a negative impact. They can't adapt. And so I will admit to you all, occasionally I've started patients on treatment just because the watch and wait thing was having such a negative psychological impact that it wasn't good for them. But most of the time I can get patients to start out on the strategy, and most of the time the patients actually do get comfortable with it and start to see the merits in the strategy.
That's a great, really comprehensive explanation. So that's really wonderful. We'll probably have patients going back to that periodically and so hearing that maybe their doctors told them but they didn't hear, and this is it. So Nicola, I think you've experienced many of the things that Brad just mentioned, that early tension, and maybe how did you deal with that, and maybe tell us how you've adjusted over the years and become more comfortable.
Yes, definitely. I mean, I was very anxious, and it took me a long time. It wasn't an overnight process of just accepting this diagnosis. It was a struggle to get my head around the incurable part of the cancer, and just not the traditional cancer diagnosis way of having treatment, having operations, and then hope for the best outcome. And so, yeah, I struggled for quite a while going on watch and wait. I just wanted this cancer gone. I needed a plan. But I think at the time of diagnosis, I was planning my wedding.
Yeah.
So I kind of had that as a distraction for the first year. So, and I think after the first year, it did get quite heavy. It was something I was thinking about. I was worrying about why I wasn't being treated and what this would mean for my prognosis. And that's when I went looking. I needed to sort of connect with other people that had this cancer. And that's where I found the Nikki's group, Living with Lymphoma, Follicular Lymphoma. So that really helps, just connecting with people.
Yeah, very interesting. So yeah, that's a bit of, well, I often find that, you know, after a couple of visits when things are quiet, people get used to it. And then when you come sometimes and say, I'm concerned that it might be time to start treatment, they go, no, wait, I'm doing fine. So it varies. And, you know, so everyone is different. And I think the Living with Facebook group does provide that patient, you know, you're not alone in this.
Yes.
And so I think that is a key resource. Did you get any help, or did out of the group or through your healthcare providers, sense of where you might look for that kind of support, or did you just find it in the Facebook group? And then what did you find helpful in sort of getting more comfortable?
Yeah, so I've been really lucky. I've had the same hematologist, oncologist since my diagnosis, and the same nurses. And they quickly realized that I was quite anxious about the watch and wait and the diagnosis. And here in Britain, we've got a charity called Macmillan. And so they sent me off to Macmillan, and I got a therapist who really, really helped me in those early days.
Yeah, that's very useful. I see a comment in the chat. Someone started anxiety meds, which they found helpful. I think it's something that as physicians, maybe we don't do enough of in helping patients, at least find the resources. We may not be the best person to deal with it, but to help you find the resources and assess that. And as you point out, often it's the nurses who are better at that than the doctors. So that's worth always asking the nurse after the doctor leaves to say, hey, I'm having trouble with this. So they often have a little bit, at least in the US, a little more time to spend with you and can point you in the right direction. So all good advice. So one of the common concerns is, how do I know that I'm still okay for observation? And so that's two. There's going to be a different viewpoint from the patient. How do I know that cough and fever is not lymphoma and it's just flu? And from the physician standpoint, we'll ask Brad in a minute what he looks for. But Nicola, so when you have the flu and you have a fever and a sore throat or whatever, and the lymph nodes in your neck get a little bit bigger because they're fighting the infection, how stressful is that? Has that often happened to you? What do you do with that when you have a concern like that?
Yeah, it is quite stressful, and I don't think that ever goes away, regardless of where you are, either watch and wait or after treatment. But yeah, I think it's happened to me a couple of times where lymph nodes have popped up, or I've had just an ailment that I can't figure out what's wrong with me. And I have sort of reached out to my hospital team. And I mean, I'm so lucky I've got a really good team at the hospital, and they do put my mind at rest. So yeah, I think as time goes on, you do get used to knowing when to reach out to your team and when to think, I'm just human, I'm going to get illnesses alongside this cancer. So yeah, I think it's just, you get to know your body, I think, when you have something like this. And I think it's really important to get to know your body and to listen to your body and respond to it.
Yeah, I think that's important. That's a phrase that I often use to patients. You'll know, and they go, how do I know? Well, you know your body. And I think that's something to be said. So just before I come back to Brad for a second, do you get routine scans, CAT scan or PET scan? Do you get them periodically or only if there's a problem? How are they doing that for you?
So my consultant, he's very good in the fact he doesn't like to do a lot of scans, obviously with the radiation. So I haven't had a scan, must be 6 years now, 7 years. And I used to go every 3 months to see him. I'd have a blood test and go in and have a chat with him. It's now gone to 5 months. So every 5 months I go in, have a blood test and go through any concerns I have. So yeah, but scans, I've not had any. And he would, if I went in and said, look, I'm really worried, I want to scan, he would scan. And I'm quite happy with that. And that took a while to get my head around it. I wanted to keep getting scans to check the size of the tumours. But yeah, I'm quite happy with how it is now.
Yeah, I must say, it sounds like you're in excellent hands, to be honest with you.
I am. I'm so lucky with my team, yes.
So Brad, that brings up lots of questions. How does the patient know? How do you know? What do you look for when you think? Because you don't want to wait for the patient to be sick before you start treatment. The goal is always to start right before they would have really needed it. And how do you sort of get the pace of disease and then what's the role of scanning? So those are two big questions.
Yeah, great questions. I do think every doctor does this a little differently. So there's no like absolute right or wrong for what I'm about to describe. I just want to make that clear. Um, so when I get a newly diagnosed patient um, who's low tumor burden, asymptomatic, and we agree to start on this watch and wait strategy, I watch them more closely in the beginning because every patient's different. And we're trying to figure out how the lymphoma in this new patient is going to behave. And sometimes, the disease doesn't budge for 7 years. And sometimes the disease is growing steadily, um, faster than we might have predicted. And I'd like to know which category we're about to be in. So if I have a newly diagnosed patient, they probably have just had scans. I'll start seeing them every 3 months. And if I'm a little worried about them, I might even do a scan like 6 months after the first one. If the disease burden was really low, I might wait a whole year. But I'm definitely going to get a scan sometime in that first year just to make sure it's behaving itself. And I'll probably get another scan sometime in that second year to make sure it's behaving itself. And if it's growing steadily, okay, now we got to keep our surveillance up relatively tightly. But if it's totally just sitting there doing nothing, then you can really start to back off. You have 2 years of observation under your belt and it hasn't budged. And so now we have a history, a 2-year history where your lymphoma is not changing at all. And then I will try to back off on the scans, which again, sometimes this is a negotiation with your patient because as Nicola mentioned, some patients really want the scans and some patients are not so interested in the scans. So you have to have this conversation, and I call it negotiation, not like we're cutting a deal, but I want to make sure the patient is comfortable and happy with the plan. And boy, if they really want that scan at year 3, I'll say, okay, let's do a scan next year, but let's agree right now that if it hasn't grown at all, we'll try to go 2 years before our next scan. Like I'll try to start planting a seed for minimizing the amount of scans because there is a modest amount of radiation exposure to every CAT scan, and the number of scans can really start to add up. So I want to minimize those if we can. So I'll try to back off on the scans if we see the disease is behaving itself.
Yeah, I think that's a good point. It's the disease is very heterogeneous, so we want to find out how the disease in each patient is behaving, and then individualize the follow-up. And again, you want the scan. What's the question you're asking? If the node went from, grew by a centimeter, but the patient's perfectly fine and you're not going to do anything, maybe you don't need it. The other thing that helps sometimes is if there are nodes that you and the patient can feel,
Yeah.
you don't really need the scan as much because you know what they're doing. If there's
Yep.
only stuff inside, then maybe I don't really know what's going on, so I might get the scan a little bit more. Sort of interesting. And so obviously if people develop symptoms, night sweats, weight loss, you're going to proceed.
Yeah.
What is there a magic number? Is there something? Is it the pace of disease? What do you look for in a patient that says, yeah, we're getting too close to the time, we're going to start talking about what the treatment options are? There any?
There are these criteria that are called the Gelf criteria. And, it's development of symptoms that are from the lymphoma. That's an important distinction. So sometimes people come in, they don't feel well, but maybe it has nothing to do with their lymphoma. So that's always something you have to sort out. If the patient just we think it's just some illness, they develop some respiratory infection or flu or some viral infection, usually these things are self-limited and then they get better with time. So sometimes the conversation is, well, this sounds like it might not be your lymphoma making you sick. Let's give this 2 weeks or whatever. You know, most of these viral illnesses are self-limited, and after 2 weeks you start feeling somewhat better. So if a cancer is making you feel bad, then usually the direction is just worse, 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 worse over time. It doesn't spontaneously, your symptoms don't spontaneously get better. So if somebody was like, boy, I was so sick 2 weeks ago, but I feel fine now, then I pretty much know it's not their lymphoma. It was something else. So we use time to sort this out a lot, because we get phone calls, not every day, but every week we get phone calls from our patients like, hey, I'm having this, should I come in and get checked out? So we have to decide. And we don't mind the phone calls, you know, that's what we're here for, to try to sort out, should we bring you in early? And if we can't tell over the phone, we'll just say, yeah, come on in. Let's check you over. I'll examine them. We'll do some labs and then decide if we need scans or not. If you do see the disease is growing, but the patient still has no disease-related symptoms, then it becomes kind of a judgment call on when to initiate the treatment. We have these GELF criteria. So if someone crosses the line on these GELF criteria, doesn't mean you have to start treatment, but it means it would be reasonable to start treatment. So then I'll start having conversations with the patient about, well, we now have this amount of disease that, for example, if you have 3 lymph nodes over 3 centimeters, the GELF criteria say it's reasonable to consider treatment. That's a soft rule though, guys. You don't have to start the treatment at that point. They say if you have 1 lymph node over 7 centimeters, it would be reasonable to start treatment. And it is reasonable, but it also depends where that lymph node is located. Some locations are bad. Like you could have a lymph node that's about to compress a ureter, which means your kidney's going to have trouble draining its urine into your bladder. That's a problem we do not want to let manifest. So we are definitely going to recommend initiating treatment, because we don't want to let that problem start. But if your 7 centimeter lymph node is in this part of your body called your mesentery, that's basically where your intestines are, a 7 centimeter lymph node is potentially no problem there, not going to hurt a thing. So a lot of this depends on location. So there are a lot of nuances to when it's time to initiate the treatment, a lot of subtleties. And it can be to your benefit to have a physician who's kind of an experienced lymphoma person who will be comfortable with observation, has a good feel for when it's time to start treatment and when it's okay to continue to observe.
Yeah, I think what I'm hearing is there's a lot of shared decision making. There's a lot of medical nuance from your side, and then also how the patient's feeling and that sort of thing. So it really does require that. I'm going to turn in a little bit more to where we are in some of the new treatments and whether they might change the paradigm. But Nicola, I want to spend a couple more minutes on that transition that you had from high anxiety to maybe controllable anxiety. And are there any lessons or teachings you have for the listeners, that things that helped you? I mean, you mentioned Macmillan and counseling, but are there sort of, what in your mindset changed, if anything?
I think, as I said, it wasn't an overnight thing, but I think the therapy really helped me control the anxiety around it. And I just took on this thought process of nobody knows what's around the corner. And I think that massively helped me. And just, I think the incurable part of the cancer, I just felt I didn't have any control. So just to take some of that control back, I started sort of looking after myself. I was kinder to myself. I started eating healthier, started exercising, and I think I gradually felt better and better. And I think just taking back that control of feeling like I was doing something, along with the therapy, helped massively. Yeah.
Okay, great. There's a couple of questions in the chat that sort of deal with, again, what we talked about, Brad, timing of treatment. One is about fatigue, which is obviously much harder to measure than anything else, night sweats, that thing. So, so we're all tired. I mean, most of us in this modern day will say, oh yeah, I'm exhausted. Do you have any measures for that? I mean, my usual thought was, have you changed your lifestyle because of that? But how do you assess fatigue in a patient, and is that ever the sole reason for starting treatment?
I would say the fatigue is the hardest thing to sort out for me, because there's so many other things that could cause fatigue. And so like you, I will start asking them questions like how it's affecting them. And, sometimes the answer is, well, yeah, I work 3 jobs, and when I get to, my 70th hour of work, boy, I just don't feel like I'm giving it my best. And I'm like, well, maybe it's because you have 3 jobs. Maybe, you know what I mean? So
Yeah.
then the next patient, you're like, yeah, I can't mow my lawn anymore. I can't do my housework. So you really got to drill down on how active they are and where the fatigue is impacting them. It's probably useful to also look for other medical explanations for the fatigue. Some patients might have undiagnosed thyroid problems, or some patients might have undiagnosed or untreated sleep apnea. And, so you have to see if there's try to see if there's other explanations for the fatigue. Having said all that, I've had patients where we've checked them for sleep apnea, and we've checked their thyroid, and we've checked for other medical conditions, and we can't find anything, and they still tell me they're profoundly affected, even though their disease burden is low, but they just have this terrible fatigue. And then I'll say, well, I don't want you to live your life fatigued if we can help that. So occasionally I've just treated the patient almost as, I don't want to call it an experiment, but it's almost an experiment to see if we can help them. And I've had it go both ways. Maybe I just treated the patient with single agent rituximab. We proved that we put your disease into remission. And I've had patients come back and say, yeah, I don't feel any differently. I'm like, okay, well, it wasn't the lymphoma. And I've had patients come back and say to me, I feel way differently, way better. Now, was that placebo effect, or was it our rituximab? Who knows? But I'm just happy that they feel better now, and then it was worth it. So there is a lot of individualization that needs to occur, and you need to have a good dialogue with your healthcare team to figure out what's the best pathway for you to figure this out.
The other question that came up was sort of interesting. We talked a little bit about, you can have the flu, you can have an infection, things come and go, and if they don't last, you're okay. But there's a description in the chat of someone who every couple of years gets some sweats and things, and the nodes may pop up, and sounds like the disease is getting worse, and then it spontaneously, or for whatever reason, settles back down. So it could be an infection that's not obvious. Do you think the disease, waxes and wanes, and how does that factor into the discussion?
Yeah, there's definitely a waxing and waning quality in some patients, and we can see this on scans, actually, where you do a scan and everything gets a little bigger one year, and then you do scans a year later and everything's a little smaller. We do see that. It would be a little unusual to get symptoms from follicular lymphoma and have those spontaneously regress, but I would never say never. So could that be waxing and waning follicular lymphoma? Sure. Could that just be manifestations of some infection that you didn't recognize? Could be that too. So these things are hard to sort out at times, but yes, definitely can have a waxing and waning quality. And some of these studies that have looked at patients over 10-year intervals something like 2 out of 10 patients have gone into like spontaneous remission in some of these studies. So that can happen.
Great. So I'm going to come back also. So, having rituximab as a single agent gives us a little more flexibility than starting chemotherapy. And could you mention a little bit about the study that you ran on rituximab in low tumor burden patients, number one, and then maybe, we'll come back then to the current experimental current options. Yeah.
Yeah, so for years all we had was chemotherapy. So we weren't really anxious to take people off watch and wait and start them on chemotherapy. That wasn't very appealing. But then rituximab came along, which is this drug that works through your immune system. It's a monoclonal antibody that literally sticks to the lymphoma cells and it kind of coats them. And when it does that, it tricks your immune system into coming and fighting the cancer. And it's a pretty nice treatment for patients. There's no nausea or no vomiting, no hair loss, no peripheral neuropathy. It weakens your immune system a little, not terribly. So this was a great new option. And so once we had rituximab as an option, we were really interested to test rituximab against watch and wait. And there was a study done in the UK that compared rituximab against watch and wait. And then simultaneously, we ran this study in the United States, which compared 2 different dosing strategies of rituximab. So half the patients got it just kind of on an as-needed basis based on going into remission and coming out of remission. But the other half the patients, we really tried to almost push the envelope where we put people on rituximab and we just wanted to keep it going. If we put people on maintenance rituximab, could we cure patients? Could we get their disease to stay away for 10 years? Could we make them live longer, which is what we really wanted to try to show. And now with long-term follow-up, what we've learned is even if you put people on the rituximab and leave them on it, it still doesn't improve the likelihood of being alive 10 years later. So rituximab can make your disease go into remission, but it doesn't appear to, even if you give it in a maintenance strategy, we did not improve the likelihood of being alive 10 years later. So we're still not recommending that strategy routinely.
Yeah, I think that's important because that's always the hope is that if I catch it early when there's low tumor burden, that would be the magic. And unfortunately, it wasn't. It's not that you don't get the drug, it's just getting it early doesn't help you compared to getting it when you hit the normal criteria. Yeah. So I understand there is a trial in the US now looking at a different kind of immunotherapy, a bispecific antibody. Can you tell us what's going on in the field in terms of, okay, watch and wait is okay, we want to do better. Where's the field going?
Yeah. Right. Yeah, I'll touch on that. I'm gonna try to weave that in with another scenario. So hang with me for a second here, because there was a great question from an audience member named Chad. And so this will tie into the study. Question for the doc. With newer meds available now, does that ever change your plan to decide to treat sooner? In essence, I'm asking, does waiting ever put the folks into chemo treatment when they maybe could have had easier treatment earlier on? That is a great question. And we know with rituximab as a single agent, once the lymph nodes start to get bigger, and a threshold in my mind is once they get over 5 centimeters, rituximab as a single agent drug, it really doesn't work as well. Rituximab works better when the disease burden is lower. So if you wait and wait and wait until the lymph nodes get to these bigger sizes, and then you want to just do rituximab, it's probably not going to work as well. And so some patients are keenly interested in avoiding chemotherapy. So if you're in one of those scenarios, it does make a certain amount of sense to not let the lymph nodes get too big. And if you want to just try single agent rituximab, or sometimes I have an older patient, maybe they're in their 80s and they're frail because they have other health conditions. And I've been watching their follicular lymphoma and I know they're going to struggle with chemotherapy if we wait too long. So I might intervene a bit earlier than I otherwise might, just so I can get away with single agent rituximab. So there are some times where you will do that, Chad, where you'll just intervene earlier. Now, the good news is if you do wait till you need chemo, the chemo we most often give the last 15 years or so is this drug called bendamustine with rituximab. And bendamustine is actually not that bad a chemotherapy compared to some others. Like on a scale of 1 to 10, with 10 being like the most intense chemo you can imagine and 1 being super mild, bendamustine is probably like a 3 or a 4. It's just not, most patients tolerate it well, and it works really well against follicular lymphoma. I saw one of our patients through a chat in there. I was treated with BR like 10 years ago, and I went into remission, and I'm still in remission. I mean, that can happen, these 10-year plus remissions. So it's not the end of the world if you have to jump into something like BR. You can get great results from that. So back to the question about these newer meds. There's a new class of drugs called bispecific monoclonal antibodies. People might have heard of these drugs, epcoritamab, mosunetuzumab. Those 2 drugs now have approvals in follicular lymphoma. And these drugs, they work similarly to rituximab, where they will bind to the lymphoma cell and try to trick your immune system into fighting, but they work more potently. They appear to be more effective. And so, like in the United States right now, we're conducting a study in low tumor burden patients, and patients are being randomized to receive rituximab. So that's sort of our control arm. And then the other half the patients are getting this newer drug, mosunetuzumab. And we're enrolling to that study right now. And we're very interested to see if you take low tumor burden follicular lymphoma and give those patients this newer drug, mosunetuzumab, what proportion of patients will go into remission, and what proportion of patients will still be in remission at 5 years and at 10 years. We're really interested in the long-term outcomes. So I think that's a good study, and I've enrolled patients on that study. Now, I don't recommend mosunetuzumab routinely right now because we don't know how good it is in this setting. That's the whole point of the study, is to learn that. And so we're right in the midst of enrolling patients on this study so we can learn. And then maybe several years from now, and we're doing this webinar again, maybe mosunetuzumab is what we're recommending. It will depend on what we learn from this study. So it's a good study, and there are other studies probably around the world like that, asking similar questions. So Mitchell and I have been doing this for years, where, we're always trying to get smarter, to do a better job for our patients. And that's how we get smarter, is we execute these studies so that we know what to tell our patients when these new discoveries are made.
Yeah, great. So Nicola, if Dr. Call were sitting there across from you, or your consultant hematologist, how would you feel about a study like that? Would you be interested in a study, or you're comfortable enough now with your watch and wait? You go, I'll just wait and I'll explore the options then. Any thoughts on how you would approach a study instead of watch and wait?
Yeah, that's a really good question, Mitch. I really don't know. I think I would have to get all the information about the clinical trial first and just really have an open, honest discussion with my oncologist and say, just get his knowledge, and just, I suppose, go with my gut. I think what I'm quite comfortable now. I've come to terms with being on watch and wait, and I'm not sure how throwing in some treatment would sort of make me feel. I think it's that feeling of not knowing the outcome of the clinical trial, but wanting to sort of help with research, isn't it? It's getting that fine balance. So I don't know. I think I would probably just, like I said, have an honest conversation with my oncologist and go with what
I
sort of
think
his
that's certainly a
opinion.
reasonable answer. I'm not even sure you would
Yeah.
fit the study because there may be things like you have to be this close to diagnosis. It might be a criteria because we know that your disease has been nice, well behaved. So it might be much harder to answer the question in you than someone who's 6 months out where, you know, there's more likelihood that they would progress sooner. So all those factors go into a trial. So it is complicated. And of course, each one is a discussion with your oncologist. But as Brad mentioned, I mean, it's one thing to say the disease is incurable, low tumor burden, we still do watch and wait. Doesn't mean we're satisfied with that. We're always trying to learn more. And one of the things that we do is encourage research along those. And the fact that we have these bispecific antibodies is you know, something we didn't have a few years ago when we couldn't ask the question. Now we can. There is a discussion or a question there about CAR T, and I would say just quickly, CAR T are more toxic, more difficult to give, more potential long-term issues. So I don't see that in the low tumor burden in the near future. If we get better at it and we learn how to give them easily, that would be easier. But even bispecifics have more toxicity than rituximab. So there's always a trade-off in terms of side effects and risk. We have about 10 minutes left. I do want to put up the third poll, which is about the biggest challenge for you, or if you're a caregiver, your loved one, dealing with watch and wait. Please try to pick one. I know many of them, you'll have many of them, but we'd like to see what you see as the biggest challenge, and that will help us sort of going forward, focus our attention. While we're doing that,
Mitchell, can I tackle a question in the chat while we're doing that?
Absolutely, be perfect. Yes.
Yeah, one of my goals was not to make anyone's anxiety level get worse, but I think I did that, so I have to address it. So there's a question here. I keep bringing up, you know, the probability of being alive 5 to 10 years later, mostly because that's what the studies, that's how long they follow the patients. I do not mean to imply that your life expectancy after your follicular lymphoma diagnosis is 5 years or 10 years. It's way longer than that. You know, I'll be honest, we don't know for a patient diagnosed in 2025 what the life expectancy is because of all the new discoveries there's going to be in the next 20 years. But we think it's in excess of 20 years. Now, it gets really hard for us as physicians to project life expectancy accurately once you're out 20 plus years. So I'm being a little vague on that, but I do want to emphasize that if you're a patient with low tumor burden follicular lymphoma, the odds are, and I say this to my patients all the time, you're likely to die with your lymphoma, not from your lymphoma. In other words, it probably won't affect your life expectancy. So I just want to make that point to everybody.
Yeah, I think that's critical. You know, it's very hard to show a difference when fortunately for everyone with follicular lymphoma, the survival data looks quite impressive. And as you say, we haven't even seen the results of benefits from the last 5 years, the bispecific antibodies, the CAR T, et cetera, because it takes that long to read out. And that's one of the problems with defining a cure, as you mentioned early on, is, you know, you probably die of something else as you know, I would say our audience tends to skew a little bit to the younger patients with follicular lymphoma. But the average age of diagnosis is in your mid-60s. And if, as Dr. Call is saying, 20 years is a reasonable expectation, you know, then other things may get to you before the follicular lymphoma. So I think that's the key thing to keep in mind. And we don't want to do harm because of that. We don't want to impact that in a negative way. And the biggest challenge, what we see is worrying about when treatment might be needed is the clear winner. Half the people find that as the major challenge. Hopefully we've addressed some of the anxiety and feeling like nothing's being done. Interesting how to explain watch and wait to family and friends. We didn't have a lot of time to go into that, but that is an interesting question. Like, you know, what your doctor doesn't know what they're doing, you know. But it is interesting. So half the patients are here to talk about, you know, how do you know when treatment? I think we've tried to address that. It's a complicated and individualized discussion, so I'm not sure we're going to get into that. One of the things that just came up, I think, and is we routinely, when you go see your consultant or your hematologist, get blood work. And they said, well, what did my blood work show? Is there a tumor marker? So the simple answer is no. But Brad, what do you look for in the blood? Are there warning signs there that maybe something is out of whack and I should be concerned? What?
Yeah. So the blood work is, in all honesty, it's not completely trustworthy. In other words, the blood work can lie to you. So we look at it and it might tell you there's a problem, but it can also miss a problem. So that's why we occasionally will, that's why we examine you, and that's why we occasionally might add in scans, because the scans pretty much can't lie. The blood work can be misleading. Now, we're doing routine blood counts, we're doing chemistries, and if we see abnormalities developing, it might be a sign of lymphoma worsening, might be due to something else. There's a couple of blood tests that sometimes are useful. There's something called LDH. If we see that increasing, it could be a sign your lymphoma is worsening, but there's other things that can make the LDH go up. There's another blood test called beta-2 microglobulin that I will check, and if I see that increasing, might be a sign that the lymphoma is worsening. But there's other things that can make your beta-2 microglobulin go up. So I do all these blood tests as part of my strategy to minimize the amount of CAT scans I get on people or PET scans. And then if I see something I don't like in the blood work, maybe that would be a clue that it's time to get a scan. That's kind of how I use that.
Great, thanks. I know we're down to the last couple of minutes, so if you can just put the last poll up. And while we're doing that, Nicola, if there was a piece of advice you could give to people on the webinar about, you know, how to deal with this positively, and is there some key thought that you've learned over the years?
Yeah, I think find out who your support network is and lean on them. I think just a practical bit of advice is take a notepad with you to your appointments, because it's a lot to take in, and it's a lot to remember. So I always take a notepad with me. That's just a practical. But I think just holding on to hope, just like whatever twists and turns this cancer takes you on, you've just got to hold on to hope that you'll be okay. And just look after yourself, I think, is what I've learned over the years. Just listen to your body. Yeah.
Excellent way to do that. I think that's good advice. So we're almost out of time. There are some interesting questions about transformation. That's a whole separate topic. Can it change to a more aggressive form? We'll have to deal with that separately. It's been in some of our webinars. It's always on this underneath, but we will deal with that in the future. That's clearly an area of interest. I think from the post-webinar poll, we've done a great job because almost everyone's in the 4 or 5 range. So I think we've learned a lot from our panelists. So thank you, Brad and Nicola, for your sage advice. Hopefully we've, and I do want to thank the sponsors. There should be a slide coming up with thanking our sponsors, and thank the participants for joining and your excellent questions. I know we can't get to everything, but we will take these on. There is a post-meeting survey where you can put ideas in for other topics. We like to hear those as we continue our webinar series. And I also wanted to highlight that we have a global patient survey that is currently live. You can get to it from our website. It's open for a couple of weeks, and we really appreciate your input into that. We use that to go to ASH, the big hematology meeting, and try to educate physicians about what they need to know, what patients are concerned about. And our next webinar will be up in November, so please keep an eye out for that. And again, please, your feedback is important. And one final thanks to Brad and Nicola for a great session. Really appreciate your contributions.
Thank you.
Thanks for having me.
Bye, everyone.